you have to experience that the chemistry is there. You have to experience that this doctor is interested in you, not just in getting you out of the office. That this doctor wants to ally not only with you, but your family or your partner, and that this doctor is going to stay with you and provide not just medication, because this doctor, you, is going to say, well, you don't have thyroid disease, but you're not eating right to get better.
Again, we have a special guest, and maybe I'll say that about every guest we have, but this one is particularly important. Dr. Lloyd Sederer is with us. Dr. Sederer, or Ask Dr. Lloyd, as he's been known on his platform for a long time, and I've been colleagues for, I would say, almost all of my career. And Dr. Sederer currently is an adjunct professor at the Columbia, the Mailman School of Public Health. He also is a prolific author, and we're going to talk about his books. And he's a leading mind in mental health in America, and I would say globally, in terms of having run one of, if not the largest mental health care system probably in the world. New York State just has so many hospitals, clinics, so much investment in mental health. And so Lloyd brings a really broad view. He's also been a clinician and a good friend and a mentor of mine. I always remember the time very early in my career as I was trying to figure out media, trying to figure out so much. So I'm still trying to figure out a lot of that. and Lloyd kind of took me aside, patted me on the back in that way that, mentors will. And he said, you're a rock star. And I always remember that moment, Lloyd. It really was, I felt seen in a way, not that I'm a rock star, but that I was trying to do something. And I really appreciated that. So welcome to the podcast, Lloyd. It's a treat to have you here. We're going to be talking about your new book, of course, but maybe you can just share a little where you are right now and tell me what I missed. Your bio is so long, we could have spent the whole episode on your career.
Indeed, you are a rock star because you have become one of the nation's leading comprehensive psychiatry doctors. So it's usually called integrative medicine, but your work combines therapy, it combines nutrition, it combines exercise or fitness, it combines medications, and it combines a variety of mind-body activities like yoga, mindful. That is comprehensive treatment, and that's what you represent, and we need that deeply in our field.
Lloyd, that means a tremendous amount coming for you. Thank you for that. I really appreciate that. Like a lot of our colleagues in this, I'm aspiring to be that and to walk that talk as much as I can. But thank you for that. Let's talk about you, though, because you really, how many books is it now? I've lost count. It's too many. We all get jealous.
14
books. Now, I've been with Lloyd as he's launched a number of books. The Addiction Solution, I know is one of my favorite because you make a point about substance use that I think rarely gets made. Do you have a copy of The Addiction Solution? Just because I think so many people listening are looking for a resource. This book is incredible because it leads with empathy. It leads with one of my favorite organizations, the Center for Motivation and Change, encourages us, right, to face substance abuse with science and kindness. And I love that, and I think your book embodies that as well. Well, let's just start there. What as a nation are we missing about substance use? Why are we having such just record levels of use, abuse, and death and pain from substances in America?
I think there are two principal reasons which I try to get at in this book. The first is that people use drugs because they work. They serve a purpose. They have an immediate effect physically, psychologically. They work. They only for a period of time, but initially when the addiction develops, they are working for someone. That's the principal reason people take drugs. And I think we have to start there in terms of reaching somebody, touching somebody in a way that enables them to begin to recover. The second is much more critical. It is that the United States has had a type of love affair with two strategies to combat drug addiction, drug epidemics. The first is border patrol, harbor patrol, basically capture smugglers and drugs.
Supply. If there's no supply, people won't use this stuff, right? If we don't have any drugs out on the street, we don't have a drug problem because no one can use them.
Well, that assumes that those intervene or that that strategy works. It has never worked.
Doesn't seem to work. Seems like there's every place I've practiced and everywhere I've sort of lived. One of the nice things about being a psychiatrist is you get to put your ear to the ground a little bit differently. You get to hear a little bit of maybe the background or what's going on underneath the news a little bit. And certainly there have been a lot of substances pretty much everywhere.
The second related reason that we're failing is that the other strategy that this country is in love with is punishment. That you are caught with more than an ounce of heroin or you're caught twice, you go to prison. You go to prison for, used to be 15 or 20 years, which doesn't do anything in terms of remedying the addiction. And basically, it costs a fortune to keep somebody in prison when, in fact, what they need is treatment. So the country invests its resources, its money, its energy, its politics in these two approaches. And they've never worked. And the best example is prohibition. So prohibition was over 100 years ago. You cannot control people's use of a substance. They have to control it, but we think we can legislate it or we think we can intimidate about it, but that's goofy. Prohibition lasted a few years. And the one thing that really developed as a consequence, I think, of prohibition is the mafia. So it created an underground industry of delivering alcohol to people who wanted it, and they were going to get it, and they weren't going to get it at a liquor store. They were going to get it through the mafia and its connections. So this, over 100 years, punishment, control of access, there's no evidence it works. And that was my premise because of the book, also because I'm a public health doctor, I'm a psychiatrist and a public health doctor. But when you look at public health has beat a whole lot of epidemics. It's beat smallpox, polio. It's reduced deaths from motor vehicle accidents substantially. And it has reduced, not eliminated, tobacco consumption in this country and COVID. So, not that that's over yet, but each of these are epidemics that were approached from a public health manner, in a public health manner, and not by control and punishment. That's where we need to go, I think.
How do people then balance if drugs work? I think alcohol is everybody's seems favorite. Alcohol seems to be the most popular. It's legal. It's promoted, and people have a lot of access to it. And at the same time, it's probably, I would say, one of, if not the top driver of mental health kind of burden in America. I would say, poor diet and alcohol, if we shifted that suddenly overnight, the mental health landscape in America would look a little different. We don't really regulate the supply of alcohol that much, a little bit, but people drink a lot, especially these days. I think that there's a kind of profound use, let's say. Using alcohol as an example, how does not controlling supply work for us? We have a lot of treatments for alcohol use disorder. I wouldn't say people love those, engage in those, that the response rates to those are, as good as they could be. So can you help us a little understand, what do we do to get it right?
You can't control people's access to alcohol. We've failed at that nationally 100 years ago. The reasons people don't use have much to do with what you're saying, which is that they recognize that anything more than a modest amount is going to affect their thinking, it's going to affect their bodies, that there are consequences from that. And that's about citizens, people of this country, understanding a drug, what it does for them, and what peril it puts them in. The worst drug of all in this country, the most deadly drug, is tobacco. So tobacco kills maybe 2-3 times the number of people that alcohol
And I
does.
think we should implicate nicotine, and just in the sense that like I would say the vaping of nicotine would, which in some ways I wouldn't say replaced tobacco, but certainly became an alternative. Is there's a lot of question marks, and I think so far the data looks pretty not great in terms of what that does to people. Lloyd, I don't want to get down the rabbit hole too much of substance use. We could spend a whole episode on that, and I really mostly wanted everyone to hear Lloyd's book. Lloyd, this podcast is in some ways about a cultural shift, starting, I think, internally, trying to honor some of the values that you were just talking about, or personal responsibility, I like to call it citizenship. And then what happens if we have a culture starting personally and locally and then nationally of mental fitness and mental health, that we're going to really work together to make sure that we are addressing the top cause of disability in America and worldwide, really, which are mental health problems. You had a real frontline seat to some of how institutions are dealing with mental health, and your most recent book, just coming out, right, is focused on that. Caught in the crosshairs of American healthcare, I think is the title. It's if I'm getting it right, and this is all about your time at a very storied institution in American healthcare and in American psychiatry and mental health. And I want us just to take us back where you are in your life. What year are we in? And I want to hear about the first time you kind of walk into this place, and then if you can, we'll get to your book.
So, the story that runs throughout the book is about the collision between traditional medicine and corporate medicine. And that happened in 1989, 1990, when I arrived at McLean Hospital as its new chief medical officer and later EVP. So I was recruited because McLean Hospital was going to go under. It was going to be shuttered or bought. Everybody there thought that was impossible. It was invincible, like Solomon Brothers, too big to fail. But it began to very seriously. And for 4 or 5 years, the hospital hemorrhaged money, millions of dollars every year, until we righted it. And the writing was a cultural shift. It was about recognizing that the model of care there was ineffective, expensive. Nobody wanted it anymore, but nobody wanted to pay for it anymore. And instead, there's a whole model of acute care, general hospital psychiatry now, which is shorter and no less effective. And people like it better. They don't want to be in a hospital for a year and a half. So that was my job, was to change the culture in order to change the practices of the hospital. And we did. And by 4 or 5 years, the hemorrhaging stopped, margins began again, and the hospital has prospered since then, which is almost 25 or 30 years ago. So there is a way to change culture, but it's very hard and it takes time, but it can be done. And my aim in this book is to show that it can be done. Here's a way of approaching it. And we better start thinking about doing that because the country is being overwhelmed, bought out by corporate medicine at this point. And you're a wonderful exception, but most doctors and clinics sing to the tune of who pays them and who controls them.
I wouldn't say that I'm an exception to that, other than I like being controlled by a very important person in this story, which is my patient.
Yes.
I like them being my boss, whether it's a 16-year-old or a college bro or a woman going through a divorce. I like working directly for them. They get to negotiate the price if they need to. They get to give me direct feedback on whether I'm doing a good job or not, and I try and ask about that. It's but in some ways, it's a little bit of a model of that old longer term expensive model, and I think as we're considering mental fitness and cultural shifts, I wonder if you can just take us back. You walk in, and it almost sounds like this is McLean, Harvard's big teaching hospital for mental health, right? It almost sounds like that. Still a little bit of that asylum model. When you're mentally ill, you're struggling, you go in for 6 months, a year, you stay, you learn skills. I think that I haven't, I've been to a few of these places. When I was interviewing for residency, I went to Menninger in Lawrence, Kansas, I believe, and famed psychiatric institution. And as you drive in there, you see it was a class. It was its own campus. And with people staying there for a long time. Can you just tell us a little bit of how you walk in and you're walking into a culture that needs to profoundly shift as an outsider? And that's a very difficult position. I've seen you in this position a few times. You're quite brilliant in it. Can you tell us a little bit about your mindset?
Well, I want to rewind to the essential, most important point that you just made, Drew, which is that your orientation is to your patient. Your patient comes first. And in corporate medicine, the patient doesn't come first. The profit comes first. There's nothing that will go on unless that clinic, that hospital, that system has a profit. Because who's in control? There are three now bodies, if you will, that are controlling American medicine. The first are private equity investors. The second are huge insurance companies. So private equities like Blackstone. The second is huge insurance companies like United. And the third are big for-profit chains. And they now dominate medical care in the United States. And they're the reason that care is worse and more expensive.
Now they'd argue, don't they argue, hey, we know money, we know business, you guys are done. Go care for patients, let us take care of the back end. We'll bring in, our very smart consultants. And since we know how to make money, squeeze profit out of anything, we're going to make this system more efficient and better.
Well, you have their line down, but in reality, that does not happen. What happens is that control over decisions, medical decisions that doctors made, nurses made, shifts to the corporate owners. And that is done principally through approvals and through, if you want something other than 5 or 8 outpatient visits, you have to have approval. And who makes that approval? You've decided as a doctor you want to do this, and then you have to go hat in hand to these companies or to 800 lines and now to artificial intelligence programs and say, I would like to do this. And those programs are programmed, if you will, to say no. I think their programs are made by the same companies that make programs for casinos because they always win. And the consequences is that so many people have tried, doctors have tried, and patients have tried, and they're defeated because they're up against the house. They're up against corporate control. And there are other consequences. So now we have 8-minute doctor visits, primary care visits in particular. Why? Because that conveyor belt is determined by how to make a profit. How many patients do you have to see? How many billings and what procedure codes do you have to bill in order for where you're working, other than as an individual practitioner, to make money? So there becomes this churning.
It gets me depressed. I'm not a modern doctor sometimes, Lloyd, because I can sit with a patient sometimes if I'm not careful when I meet them for 2 hours. Because there's so much to hear about when people have especially complex psychiatric histories, and especially with mental health, often mental health in our families, right? Developmental stuff maybe you haven't told people about. it takes a while to also form a relationship and share that stuff. There's a lot of stuff I don't tell my primary care doctor because I just barely know her. I remember when I went in last winter, I was having a really hard time, and I went in, and it was a tough time for me. It's really hard to just let it out, because I barely knew her, and I knew she's a great doctor, really caring. Everything she did was good, and so this model that we have, it does get me a little depressed. Somehow I'm old and antiquated, right? I just want to sit with my patients for a long time.
No, you're
I want
value
to hear.
driven. You're value driven. I'm sorry to interrupt.
Well, that's okay, but I'm wondering, how do we get that value in? Do we pass a legislation saying there's no more prior authorizations? I mean, because the solution I've found, being in private practice, building a little bit of a platform, it's bothering me, Lloyd, because there are a lot of people in the community I'm in who only have Blue Cross Blue Shield. And there are a lot of people in the community I'm in who need probably a different type of service than the one that I'm a little accustomed to in New York and here on the internet during COVID. And so I'm wondering, in terms of some of the solutions, can you give us a little hope that there are a few in terms of, I guess for us personally, right? Everyone listening is like, okay, this system maybe stinks. Like, are there solutions that you see in your own life or in the book that you find that you can help give us a little hope?
Yeah, the book is a good outcome book that you can win in this.
Oh, good.
You can win. But there's an African expression that says one stick can be broken, but a bundle of sticks cannot, which translates for us into, if you try to beat them as an individual doctor, you'll be run over. You won't stand a chance, or as a patient. So it is about coming together as doctors in a hospital, doctors in a practice, doctors in associations. And basically, the solution that they need to achieve is not legislation, because legislation is always porous. For years at state mental health agency where I was, we tried to control their use of this prior authorization, bring in their medical necessity criteria, say they had to standardize them. And that sorry plan went on for years until now, finally, the governor of the state says you can't deny prior approval in hospitals for these conditions. How is that going to be enforced? The enforcement lies, or the battle lies, at the doctor and delivery level. It is about doctors seizing back control over decisions so that they can take care of their patients rather than take care of the balance sheets of these corporate owners. So it is possible, but you have to come together and don't pretend that you can do it alone.
I'm smirking a little bit because one of my favorite shrinks on Instagram, psychiatrists on Instagram, Kicking Shrink, and he just posted about, the named the doctor that he's talking to on the prior authorization, name the reason, that rejected because hasn't tried another SSRI antidepressant. The patient's on Cymbalta, an SNRI antidepressant, sort of. And everyone listening, this gets important because, behind the scenes when you leave and let's say we make a decision, I'm your physician, I'm your psychiatrist, maybe I call Lloyd, get an extra expert consult. We make a decision, you need something. Let's say it's something simple like Prozac, a generic medication. Sometimes after that, I write my Prozac prescription and I get a text from you. The pharmacy says they've been trying to contact you, which often isn't true. I've not received any notification from the pharmacy that I'm aware of, right? They've been calling you or emailing, right? They can't get a hold of you. You need to do a prior authorization or something like this, right? So then you, sometimes it's quick and in your EHR, you tap, 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 it's all done. But sometimes you end up on the phone and 20, 30, 40 minutes of unbillable time in the middle of your day sort of evaporates as you're trying to argue for something that every medical student knows is an entirely appropriate, first line treatment. And it's a piece of where insurance companies make a claim to control costs, but I think everyone can totally agree the proof's in the pudding. They've just failed to do so. Healthcare is more expensive than ever. And in part, it's expensive because simple solutions I'm not saying that Prozac is the only or even my favorite, solution for depression. It's just a good example because it's $5 to $10 a year. And for some people, let's say half of people, 60, it really, really helps with symptoms. And it's just ridiculous that physicians, nurse practitioners, medical offices are spending so much time trying to get a generic medicine or a new medicine. My favorite, the newest medicine comes out. It's supposed to be better. It's better than anything else. We'd think, boy, we'd rush to get that to patients right away. There was a study about healthcare provider burnout that came out in March. We're offering the protocol in a couple of weeks to the healthcare providers of this community. What is that? Six months later, because it's our job to get better. You see it and it works. Let's get it to you. See if it works for you. And it just seems strange to me that those become the hardest medicines to get, the most expensive.
The second element to that problem, Drew, you're mentioning that you can't get less expensive and still as effective treatment. The second is that corporate medicine siphons off 15 to 20% of the healthcare dollar that ought to have gone to medical care. And there's a fancy term for that. It's called the medical loss ratio, which is essentially how much that corporation is going to siphon off. And it's got to be 15% or higher because they have to pay their investors. They have to pay for the huge administrative costs that have been created. Where has personnel increased in healthcare systems? In clerks, in administrators, in billing offices, and doctors dwindle. There is now a continued exit from healthcare by doctors. It has started with COVID.
Well, we also just let's, in terms of specifically to think about mental health and psychiatry, there's been a profound shift as institutions, I think in some ways are struggling. And I wonder if you think there's a similar shift happening, that the model we have, let's call it outpatient care, IOP level maybe is a mid-intensive outpatient program, and then inpatient care. Do you think there's something you see out there innovative that is trying to, I wouldn't say to replace that, but to modernize that?
Yes. That's why I keep referring to you, because you are at the tip of the spear. You're the doctor who's saying, I'm going to figure out a way to get beyond just being allowed to prescribe a generic medication. I'm going to talk to you. I'm going to look at you. I'm going to talk with your family. So you are taking a stand. You have a clear medical point of view. And the extent to which that disseminates among the medical community, so that the doctors are saying, hell, I don't want to do this anymore, but they're saying that by leaving the field, that the workforce is continuing to diminish after COVID because of one of the principal reasons you mentioned is burnout, which is that doctors are used like they're carburetors and that they can be fired up more. And then the other element that doctors experience has been called moral injury, which is when you work in these systems of care as a psychiatrist, like me, you are expected to follow not your rules, but their rules. And their rules are not right. Their rules are profit driven. And you still do it because you want to hold on to your job. You care for your patients. You think you're going to be able to do something, but that eats at you. And that's called moral injury. So you're not only burning out, but you're also feeling like you're doing the wrong thing morally. And what's the solution? Get out. That's a big part. But you keep saying, well, where's the hope here? The hope here is that change only occurs by necessity. It doesn't change because it's a good idea. It doesn't even change principally, even economically. It changes because there is collective opposition and morally based, that doctors want to do and that patients and families want. We're all in the same boat. The patients are being denied the treatment that you're trying to get. So it is possible. But as I use this case example of an iconic Harvard hospital where I was a medical director and executive vice president, that it hewed to an old and dated model of care, which was affordable, and it was like a red alert to the insurance companies, like, oh, we're not going to go to that place because it's going to cost us tens of thousands of dollars more. And more for what? More for a model of care that has had no proof scientifically. There was no proof that long-term inpatient psychotherapy worked. And moreover, and I wrote about this with Bob Drake, a colleague, there's evidence that, strong evidence, that long-term model of care is regressive. And what I mean by that is when you live in a controlled community, in a locked community where decisions are made for you, where food is given to you, you lose your everyday functioning. You become more helpless. And that's called regression. And so it's not just the cost, it is actually a method that does harm.
Well, and it comes from, for everyone, this idea of regression comes a little bit from the psychoanalytic history, that as you get into a treatment, as you lie down on a couch, or as you, or even just get into therapy and share more, there's something a little quote unquote regressive, because as you open up more, you become a little dependent on the therapist. Sometimes the regression is to like an earlier stage of development. You'll be a little more adolescent. Maybe you'll yell at me a little bit more or act out a little bit more. Or maybe I say something that you don't like and you go out and get kind of drunk, right? And but the idea is that bubbles up a little bit and is contained by the treatment. And there's longer term hospitalizations for some patients, as you can imagine, everyone. It in some ways it's a relief. You're struggling with, say, addiction or suicidal depression or mania or psychosis, takes you out of your life, which is a relief, because however you're behaving in an atypical way for you, you can kind of have privacy to get that under control, understand what it is, get a treatment plan going. But if you're there for too long, everyone can imagine, if you're not having to deal with things like laundry or food, and again, when people need to be hospitalized psychiatrically, sometimes that certainly is the case for a little bit. But too long just being there in a somewhat artificial environment.
Yeah, let me come back, because there is a gradient of capacity to work in psychotherapy, particularly explorative psychotherapy. Someone is going to come to you, they've had depression, they've had relationship problems, they can't make a life, their body is going bad, and they have the ego, the capacity to examine themselves, to, with you, confront what's getting in their way, and to make a new life. That requires a significant amount of mental capacity, which people who are psychotic, they just can't do that. And people who have other cognitive problems, particularly from psychosis and other severe mental disorders, they are not candidates for psychotherapy. Maybe they are 5 years after they have recovered from their acute illness, that they have a life, they have a job, they're contributing. That's when and McLean was doing long-term psychotherapy for people with psychotic disorders, schizophrenia, bipolar disorders. So it was what and I tell some stories. I always like stories in the book, and 3 of them are stories of patients I was involved with there. And one of the stories is called An Iatrogenic Illness. Now, few people know what that means, but it's a euphemistic way of saying that the doctor or the treatment makes you sick. Iatrogenic. It's caused not by the disease, but by the doctor. And
It's the opposite of the Hippocratic Oath.
absolutely. So that, in the process of changing the culture and the model at McLean, that meant saying, this is what we're going to do. And now that's a hollow thing unless you move on it, unless you actually begin to find those at the hospital who understand and can move in their method, and essentially making it so that those who don't can't make a living there anymore, and replacing them with doctors, psychologists, social workers who understand the difference between psychotic illness and what's the treatment, and shorter term care, because less is often more, but sometimes it's not enough. At Office of Mental Health, our average length of stay was said to be as long as needed. And this was the safety net. If people failed everywhere else, they went to the state hospital.
That I worked on, you were my boss for a while. We probably should have said at the beginning that when I was a resident, I remember the first time I saw you. I was a young faculty member, but when I was resident and you were the medical director, chief medical officer of the New York State Office of Mental Health, I was training at Columbia, and I was on the Washington Heights Community Service, which is a very storied unit. It is, and one of the things it's known for is just what Lloyd said, that, as long as you need to be there in an appropriate way, not in that kind of old asylum way, but in an appropriate way. And for both patients and for families and for clinicians, knowing that we had an inpatient unit, we were mainly working with a severely mentally ill population. Most folks had a chronic paranoid schizophrenia, schizoaffective disorder, or severe bipolar disorder diagnosis. So that notion that we could go into an inpatient unit, someone was acutely psychotic, and not have to stay for 2 weeks, maybe just stay a couple days. Maybe they, had a little drug experience, or just had a little med change, or missed their meds, or whatever, and then have them come back out, kind of a little seamlessly, I would say. It was so good for everyone to know that there was a sort of, the levels of care were coordinated. And then if people were really struggling, it was the only hospital I ever worked at where there wasn't a pressure to discharge right away.
Yeah.
There was concern, as people were admitted. You want to start thinking about what we call disposition. What's going to happen? What are the challenges in that disposition plan? But people could stay as long as they needed to. And I really remember that very well. I remember the first time we walked through the Audubon Clinic on 163rd Street and Audubon Avenue. Really incredibly, just a wonderful place in terms of community psychiatry. And that was some years ago. Sorry to go back through memory lane. Speaking of patients, but tell us your story about the iatrogenic patient.
So I was, we're trying to change the culture, and I started to do some things. And then I asked my colleagues, who is the longest stay patient in the hospital today? And they all knew who she was, because she had been there more than 1,000 days. More than 1,000 days. And I said, why is she still here? And we were exhausting her trust account, and her insurance company was going to say, enough of this. So she basically would be, winding down her capacity to live financially if she ever left the hospital. So this was a tough situation. And I asked these doctors, well, because several had taken care of her. They went from one to another, one ward to another. And they all said, well, when it comes to discharge, she just becomes acutely suicidal. She bangs her head against the wall. How can we discharge her? And so they would continue the care, but nothing would happen. She wouldn't get better. And so they would transfer her to another. So I identified this patient. And as you know, I leap off cliffs. So without looking. So I said, well, I'm going to be the patient's doctor. And everybody was relieved, and they thought I was a fool, which is mostly true. So I took on the care of this patient. And the first time I met with her, I said, your illness is us. The hospital is your illness. You can't leave here because you have become so dependent, and your temperament, your nature is anxious, dependent types of personalities is such that you grow enormously anxious, and you'll do anything to hold on to those attachments, to the doctor, to the ward. You'll do anything. And that was, but I asked, did she ever, because she always said she's going to kill herself, did she ever, ever in the 1,000 days try to kill herself? Or did she mostly scratch herself and bang her hair and scream? She never made an attempt on her life, which I took to mean that her protests were driven by that anxiety, but they weren't deadly in their outcome. And so I just said to her, we're your sickness. We are your illness. The hospital, you have become so dependent on this hospital that you can't have a life anymore, or you think you can't have a life.
And what happened? You treat her for some weeks, some months, then you get a plan. It's going to be discharge day. What did you walk her out yourself, or what happened?
So I said, you always need a time, something to be time bound. So I said, well, we're going to have your discharge date. You're going to leave the hospital in 4 weeks, in 28 days. And actually, she had money. She had family that was willing to help her find a place, that was already trying to get her out. But she was a well-resourced person. She was an intelligent woman, but she was very disturbed in this one particular way. So here's so a discharge day comes, and she's, her family's ordered a car to pick her up with her suitcases and whatnot. And she goes surprisingly without incident. And then the next day, because the hospital switchboard the next day said, remember switchboards, they called me and they said, your patient is on the line. And she was on the line. And she said, doctor, I was kidnapped and I was beaten and I escaped and I want to come back to the hospital.
How'd you feel in that moment, Lloyd? I mean, you put a lot of time and effort. You're trying to set an example in the institution. You're trying to shift a culture. Kind of, you said you sort of jump off a cliff and wait. I'm going to be her doctor, and how'd you feel in that moment?
I felt like I wasn't done. Seldom, when you want to make a big change, it doesn't happen at one time, all of a sudden, with one effort. So I thought, well, this is the next stage. We have her out of the hospital. She wants to come back now, but I'm going to meet her at admissions and say, I'm not taking you back. I'm not taking you back because we are your sickness, and I don't want to continue in that role as a medical director, as a hospital. We are no longer going to contribute to your problems. So you have to leave in order to escape us, in order to escape an iatrogenic illness. And, she yelled and screamed, but was in touch with her family. And another car was sent to pick her up. She still had her suitcases, and this story of abduction was totally fictional.
Huh.
And how did I know that? Well, she had smeared some dirt on her face, but she had no trauma. And her bags were, full. How do you escape with 2 big suitcases? And so she had made up this story. I don't know whether she believed it or not. And frankly, it didn't make a difference.
People really do believe their stories. Lord, as I'm listening, I'm feeling this creeping. So many people have an experience of psychiatry, or I'd say even view psychiatry like this, that we cause a lot of iatrogenic illness, that we give a lot of medicines. There's a lot of question about whether they work. There's a lot of concern. I felt, I would say, embarrassed at times where I've been so shaken at times in my career about all of the pushback. I haven't been able to do something really simple like prescribe Zoloft with confidence. Like, hey, I've done this a couple hundred times. Like, who knows? But my sense is this is a great choice. And this is, I'm hearing you speak, and I'm wanting a little hopefulness in this. How do people differentiate between the part of mental health, and I'd say psychiatry, that does cause iatrogenic illness and isn't practiced responsibly, and the type of care that you see as possible?
It's such a great question, and I have to come full circle to you because if I have a disorder, depression, I can't make a life, and I go to see you or a doctor that actually is going to truly help me and not just prescribe a generic medicine, that when I go there, and it helps to go with someone you trust, a family member or friend, uh, the question is, doc, you're not passive. The question is, doctor, how are you going to help me? And if the doctor just says, well, I'm going to prescribe some Zoloft or generic, here's the prescription and come back in a month, then you know you're in the wrong place.
I've been asked that a lot recently because I'm out here in the West in Wyoming. The model of mental health is, I've been in Manhattan most of my career, right? Where there's a kind of, I wouldn't say like a cliche, but there's a prototype, right? A Columbia or Cornell or NYU trained psychiatrist. We all do psychodynamic psychiatry and psychotherapy a little bit, or most of us, and we prescribe some meds. So people have been asking me this question. And my answer has been kind of curious to me. I think it sounds something like, I'm hoping to have a conversation with you like no other.
That's a great thing to say to a doctor. And when someone says that to you, Drew, what's your reaction to that?
Well, I'm curious about it as a patient. What is that conversation? And if I'm in the patient role, and I hope there's a curiosity around it. And I hope people hear it as an invitation. I think it's also a little frightening and mysterious. These days people like protocols, meal plans, a lot of labs, right? We're going to check. Then for sure I can, that's part of our treatment plans. It's just after you practice for a long time, you want to screen out thyroid illness, but the majority of people who present with depression and anxiety don't have a thyroid illness. You want to screen out anemia or B12 deficiency or folate deficiency. Sure, for sure. For the majority of patients coming to us, that's not why they're suffering. That's not where their pain comes from. And I think as you practice for a while and you hear the complexity, it feels like part of it is having a conversation that's different, and an alliance that's a little different, and then a set of goals that they honestly don't really make sense in medicine. When you practice in a way that's a little, diagnosis is super important, but where people aren't required to fit right in that bipolar 1, bipolar 2, major depression or anxiety disorder kind of box. And their problems like marriage that hasn't been actively maintained or repaired over the last 2 or 3 years, or role transition at work that went badly a couple years ago, or what happens when people say, what always popped into my mind? This thing that happens in high school, same with somebody who's like 60. This thing that happens in high school, I can't, every time this happens, I get flooded with this feeling and I see this thing and I've never told anyone. I think it's hard to explain that to corporate medicine or to people of it's in some ways trying to explain the value of a piece of art. It's really in the eye of the beholder, and when you experience it, you get moved by a piece of art, right? You have to. It's a very personal thing.
I think it's a personal thing when you go to meet your doctor, your psychiatrist, psychologist, because you have to experience that the chemistry is there. You have to experience that this doctor is interested in you, not just in getting you out of the office. That this doctor wants to ally not only with you, but your family or your partner. And that this doctor is going to stay with you and provide not just medication, because this doctor, you, is going to say, well, you don't have thyroid disease, but You're not eating right to get better. Nutrition is medicine. That's what, you're emblematic of that. Nutrition is medicine.
That's one of the pillars that we just, even storied places of McLean just and still kind of ignored. It's strange to me. You go to an inpatient unit or a rehab facility. Some are doing a great job of this, but more than I would say in the private sector. But you go in and you're in a place where there are some basic fundamental mental fitness tools. And we call them ADLs, activities of daily living for some people, right? Whether it's shopping and cooking, or a little bit about nutrition or sleep hygiene. And it's always been, I appreciate when people are on an inpatient unit, they're not often in a state of mind to be learning, growing, building tools. But oftentimes in those last, few days, week, people are. And it struck me that that's not kind of how we're oriented. We don't have a very robust preventative model
Right.
in mental health in America. It's one of the things I liked about nutrition. I still like about nutrition. There's data. You shift a college cafeteria and put everybody a freshman year on a more Mediterranean style diet, the data suggests you will reduce the depression load at that college or university by a significant amount. Is it perfect data? No, but boy, I like be sure fun to see that translating, see that embraced in a way that, I think this new generation of folks really is. They're very, given their mental health is being challenged like never before. There's an interest in more tools. Lloyd, I wonder if you could share a little bit personally. Oftentimes I want to hear a little bit about and I'm sure everyone listening wants to hear a little bit about what's worked for you in managing your mental fitness. You've been through some really, really significant ups, and you've been through some significant downs, and some challenges, whether they're medical, whether they're institutional, whether they're personal, and you always kind of come out fighting. And there's something incredibly tenacious about you that I really admire. It's one of the things as a mentor I love so much about you. I wouldn't exactly say you jump off cliffs, but you charge into things, and I'm wondering a little bit on your own kind of personal care when you are in a little funk or down or not doing well. How do you handle that?
Well, I will answer your question, but I want to make sure that I offer the why we can be optimistic, why change is going to occur. And a recent blog article I wrote was titled, "Who's Minding the Store?" And who's minding the store? Well, these corporate medical systems or corporations. And what they're doing is essentially putting themselves at a business, because you need doctors, you need nurses, you need patients who are getting what they need so that they speak highly of you. You need that. And if you don't, you're going to fail. So, what it's a painful road there, but what it means is that these corporations need to discover that they can't maintain their business unless they let doctors do what doctors need to do. And I think that will happen. And I think that will happen because doctors are trained, and many of them are hard-headed like me, and they're just not going to take this crap anymore there. And rather than leave, they're going to come together in associations, maybe even a union, that essentially is their way of saying, we won't take it anymore. You want to retain us? Here are the conditions. And it's not pay. It's not pay.
I think sometimes people can have empathy for their own physicians. I find my patients are very kind. They ask me how I am, or if I look a little tired, or have a little call. They ask. It's one of the benefits of having a little bit of time. But I've been really dismayed, concerned to see the number of physicians leaving medicine. I think sometimes it's hard to have empathy for physicians as a field. Generally we're known as maybe arrogant, well-paid. That I hope is shifting as people are more mindful about how they use the privilege of being a physician. But I think it is worthy of everyone's attention, and I guess I'm sort of bringing it up right now, where everyone listening that it does matter a lot when you say something nice, and it's important to note physicians are the top professional group for death by suicide,
Mm-hmm.
and when we have a system that people talk about like canaries in the coal mine, it's like there's no canaries, like it's just a coal mine. That practicing medicine, unfortunately, in this environment takes a profession that's already quite challenging. This week I've heard about a lot of the best of what can happen to people in life, but I've also heard a lot of the worst, and it sits with you. And I have it light as a psychiatrist. I'm looking across the street at the emergency room. One of my colleagues working with me here at Spruce Mental Health is Jeff Greenbaum, who's been the medical director here. Sometimes and I'll see him and he'll have an overnight shift. I'll see him the next day, and we'll have heard on the back channel about something real bad happened on the mountain, and that he was there witnessing every moment of it, trying to save a life. And so it sits with you. And so having a system that promotes our physicians and nurses and all of the folks in healthcare, it really being not pampered, but I'm going to say nurtured, and nurtured at the various stages of their careers, and then more robustly supported. That's where I love one of our colleagues, Dr. Jessie Gold, who's
Mm-hmm.
in Washington, where she's just one of those, another very vocal, wonderful doc star who is really just speaking so actively about this, or Lauren Mayer at Columbia talking about burnout. It's become a big topic. I don't want to belabor it too much because I want to get to your mental health tricks, tips, ideas, things you love. Like I'm a big like hummer and resonator when I'm feeling pretty like that. That always kind of settles me down a little bit. Or Lloyd, share a little bit about how do you take care of that like big brain of yours?
So, just to say, it's our job as those who are really uncomfortable, ethically uncomfortable with what they're being asked to do, to convey that to patients, to families, that you agree with them, that they're getting lousy care, that you can't do what you. So it is about extending that observation, that experience, that doctors are being asked to do stuff that they shouldn't. And that's how change occurs, because then suddenly you're surrounded by people who say, my goodness, Dr. Ramsey, you're so right. You're doing the right. That's how change occurs. But to answer your question about how my mental fitness, there is one overriding factor or part of my life that does that, which is relationships. Supportive, enduring, trustworthy relationships. And that's what I discovered with you. That's what I've discovered in my family, my marriage, and friends. That's and grandkids. That's what sustains me. That's when I say, I'm not going under. And these people don't want me to go under. And they say, well, let's go to a movie, or it doesn't matter. But they're there because they believe in you, and they trust you, and they want, and that they're going to be there through the bad times and the good times. That's the most important thing. And that it's not just my idea. That was demonstrated by the Harvard longitudinal study, which went back to 1937 with Harvard undergraduates, which asked the one question: what predicts a long and healthy life? And relationships, trustworthy, supportive relationships. That is the best predictor. Now, there are other things that make a difference that you emphasize. I have been, I wouldn't say addicted, but I need exercise. I know I need exercise in order to function mentally, in order to not get too discouraged. And exercise for me is a drug. And I've been using it as a drug since I was a teenager, and I still use it. I can't use it as much. But the key thing is that when I look around to the people that are the most important in my life, I think I'm very fortunate to be with them.
Well, you invest in that. I mean, I felt very both an intentional outreach by you as someone in our field, someone who I don't know could tell I needed a little help, support, that I was doing something a little non-traditional. But so I was really struck. I saw you do this with a number of doctors my age. You know, it's sort of like with each generation, it feels like you've really been very intentional about forming relationships. It's been, I think, in terms of your mentoring for me, when I think about my relationships with Greg Scott Brown or Jesse or some of the younger Suleiman and folks Sulman on Instagram, or David Pooter. And I definitely feel your presence with us in terms of, they're mostly my age, a little younger, but my desire to connect with them and encourage them and build relationships with these folks. I very much felt that your impact on me in my career. Can you give us a little detail how it works for you, though? Is this that every day there's in your journal a little like check by like relationship repair and maintenance, or a little check by exercises? I know that my wife's been telling me to go out here and run. I'm pointing to the elk refuge out here. Go out and run to Miller House. I mean, she's been hounding me for a week, and I'm having a hard time. And I've gotten suspicious that like I don't want to give it to myself somehow. I'm not sure what that is. So I'm just wondering if you can tell us a little bit about the specifics of how you do the relationships and the exercise, especially those are hard things for people. It's easy to say and a little hard to do. We all feel a little funky with our partners or with ourselves sometimes. So you can watch the little specifics day to day, what it looks like for you.
It's about reversing the lens at that point. It's not about, I can't do this, too tired, whatever. It's about, I need to do this for you, not for me. I'll get a lot of reward from doing it. But if I'm cranky, if I'm depressed, if I'm critical, which I can be, I am hurting somebody and I'm hurting a relationship. And I can't live with that. That will help me get back on the track because I don't want to lose that person. I care about that person. And like you, I care about a life of contribution, not a life of criticism and dependency. I want to give, and giving is getting, so that I'm oriented to what am I doing that is right for the people I love and respect, like you. And if I'm not, what do I need to do? Because that's my job as a person, not just a doctor, which is to care for the people who care for me. And it's nothing, I think, as motivating, at least for me, as that perspective.
When I love what you shared earlier, you're not going anywhere because people here want you and need you. And I've been thinking a lot about aging and how there's something that feels shifts in people. There's not like I don't know, almost like panic I hear in folks in their 40s and 50s, right? About like it keeps happening to me where I'm leaving the 40s and I hear people talking about stuff in their 40s, like doing this or he did that, and I think like, oh yeah, I'll do that in my 40s, and then I was like, no, you won't. Like those are God, and they were a great decade. But is this one of the pieces that you've learned about staying focused on the here and now in terms of contributing, maintaining relationships? And it's also something you said of being aware that people are delighted with you, want you, enjoy you, engage with you. I think that's a hard thing for people to know.
It's a hard thing to experience because you feel embarrassed when somebody says, "Oh, you're so true," blah blah blah. But the key point, a key point here, is that your ethics, your morals, are to serve, and they're to serve your patients. They're to serve your loved ones, and that will make for a long and healthy life, which most of us want. But going to that transition point that you just mentioned, that's been written about by philosophers, and most recently by David Brooks, the New York Times columnist. And it's been termed the second mountain in a person's life. And so that the first mountain is one about performance. It is about, I got to get a job. I have to earn enough money. I have to gain position. I have to have children. This is all performance. And it is the core of those first 4 decades. There's no denying that. But then what happens? So you have a good living, you're respectable, you have a good marriage, and then you wonder, well, is that it? Do I just keep doing the same thing? Do I keep just trying to earn more money or whatever? No. That second mountain is about turning to the moral obligations of your life. It is about contributing. It is about giving. It is about not taking. It is about loving. That is not performance. That is a different mountain. And when we climb it, the experience is that we have a life, we're fortunate to have the life that we do, and we want to continue to live. And that affects our bodies and our health as well. So that's called the second mountain, and it's predictable particularly for high performance people in there after their first 4 or 5 decades.
That resonates a lot. I mean, I think that's probably about where I'm in the foothills of, having done some performance years. I'm wondering a little bit, for you as a psychiatrist. I think something that I've been sitting with, and I'd say maybe I'm maybe embarrassed to say a little bit struggling with, is I call it the almost like effervescent nature of that's not the good word for it. The more I'm sitting with being intensely with people for a brief period of their life, and then not knowing what happens sometimes, and often, right? And I'm wondering if you think back about this patient at Harvard, and I was as you were talking, I was wondering whether, in some wild way she'd hear this, or a family member who was with her and would hear it, and that you did something decisive, you did something bold with her, you tried to kind of liberate her and free her. And I think I'm struggling a little bit with the sort of how to know what happens and why, is I think understanding something probably about that performance mountain. That as I'm sitting with now patients for, I don't know, 30,000 hours. I mean, it's been, all besides the writing and the media stuff, sort of the clinical work's really been my passion, my focus. That was a long-winded question, Lloyd. Since you've been knowing me a long time, I'm sure you can decipher what's in there. But I'm wondering if you can share a few thoughts about that before we close up.
I hear you, but I don't understand what your dilemma is. What is the dilemma that you're talking about, that you're maybe a little even ashamed to talk about? What's
I think it's probably that I see a lot of individuals at my stage of the career where there's probably a bit of a bias, and when there's a notion of how we think about the value, efficiency, and quality of the services that we provide and the impact on individuals, when sometimes we either don't know what happens, or there isn't as perfect an answer as we'd like. Someone has a diagnostic mishmash, and it's and we're with them for years, and someone has an idea about them that really resonates, and we feel, we kind of missed it. Maybe it's not sure I'm putting the question.
Yeah, no, it's a beautiful question, as usual, Drew. And as usual, I have a simple-minded answer, which is when I start to work with a patient or family, I ask, what is it that you want? What are you here for? And we're not going to be vague about that. We're going to be clear, that you want to progress in your career. You want to finish your PhD. You want to have relationships that don't hurt you. What do you want? And those become the objectives, what I need to pay attention to, and what you as a patient, am I getting what I came here for? And that's, the best patients are those who are informed and determined to see that they get what they need. They're the best patients of all. And doctors need to recognize that. When someone comes into your office and they have objectives, they have determination, you are really lucky because you have a partner. That person has a partner in their life change, as opposed to somebody who says, I just can't get up. What do you want? What is it that you want? Not just to get out of bed. Why would you want to get out of bed? So that's that led to my over, uh, excessive interest in a measurement in psychiatry and medicine, which is, if you don't know where you're heading or what your objective is, how are you going to get there? How are you going to know that you're in the right place? That was, the McLean story. I introduced a very rigorous measurement system of where with patient self-reports, patient's experience of care, not just none of this baloney as a food good and whatnot. And were they being, was it problem being explained to them clearly? Did they feel like what was being asked of them would help? This is all about respecting somebody, even to help them respect themselves. That's that's my simple-minded answer, but give it a try. Give it a try.
Well, I think what you're saying is look and acknowledge the bottom line of why people come to see me clinically, and enjoy the successes they have. And I really appreciate what you said about patients, active patients. I think everyone listening should look for providers who like working with Dr. Google. And I think that a lot of patients come and says, I looked on Google and they wince. And I appreciate that. When Dr. Google first came on the scene, we were all a little defensive. And I think things have shifted now where patients are able to be so informed. I have a few patients who have rare medical conditions. And I say to them, look, you're going to have more expertise about this condition than 99.9% of the doctors that you see, because there are only a few people who know about it and really have expertise in it. And the rest of us are here to support you and understand as much as we can. But
help you understand better what's getting in the way. Why are you not achieving that? Because often, we're often psychologically very blind to ourselves. We know what we want. We think we are doing it, but are we doing it? That's a role of a good
therapist. How do you check that, Lloyd? Is that where those relationships come in for you? That do you ask people, hey, I'm moving forward in this direction, and am I missing something? How do you make sure that you're not being blind to things in your own life?
That's a great question. The times where I've been, bottomed out, where the plug has been pulled from me professionally, are the times where I beat on myself more than ever. And those are the times where someone who cares about me says, it's not your fault. They didn't get what you were trying to do because of them, not because of you, or they didn't want to do it because of vested in. So somebody is saying to me, don't beat yourself up. And if you really try to do big things, you're going to have some moments where you get fired and you fail. And if that doesn't happen in your life, as has been said, you're not trying hard enough.
I love that about you, Lloyd. That's really helpful for me to hear right now. I think at this venture point in my career, and I think it's important for all of us to hear. I think one of the things that Lloyd has demonstrated to me, everyone, is his commitment to living according to values. his commitment that he has an idea for a book, he's going to write it. There have been all these summers where Lloyd's gone off and he's been someplace usually quite interesting. But he'll post a photo of his writing table. It's another way that you've influenced me. I'm at work on book number 5, so I don't know that I'm going to catch up to you. It's going to be tough. But I keep taking pictures of my writing table.
You have a lot of time. I didn't have 5 books by your age.
Well,
so anyway, that's what someone who cares about you, who loves you, Drew, says. Don't criticize yourself for a position that you're in, which there's no reason that you should be critical. You're going to knock out a bunch of more books, and they're going to be even more expressive of what you understand makes a difference, what's important. And I look forward to those.
Thanks, Lloyd. I'm a little choked up, everybody. That's, when you wonder about, I would say some of the key tenets to mental fitness and feeling successful and feeling mental health. Lloyd is very meaningful to me, being a dear friend and mentor, but I think you just kind of witnessed in some ways how that works. And those of you who have folks like this in your life, that it's someone who knows you, cares about you, loves you, and says straight things to you about your life. And I also want to share, there have been points in my life where I didn't feel that. I met Lloyd at a period where I had I remember I had some sort of meeting about, I saw something about like mentors, the importance of mentors, and I was kind of scratching my head a little bit. I mean, I had some professors, some teachers, I had colleagues I liked, but what does that mean exactly? And Lloyd came into my life shortly after that, and I've had a number of other just wonderful individuals who's cared for me in my career and my mind in a way. And so, if you don't have them, they're out there, and as Lloyd notes, they're the most important thing besides our personal relationships. Fostering professional relationships, asking someone for help, asking someone for their guidance. It is one of the best investments to make as a professional and as a mental health professional, for sure. Widen that circle, as of our guest, some of my friends, Tanmeet Sethi, said to us. Widen your circle. Lloyd, you leave us with some real pearls about maintaining our relationships is really the most fundamental key to mental fitness and also exercising. I'm wondering, can you leave us with 2 things? One is a favorite kind of prompt or question for someone we're in relationship with that will help us deepen our closeness. That's question 1. Question 2, what's your favorite go-to exercise, and what's your favorite go-to brain food?
The answer to the first question is asking people who care about you, how am I doing? What's it like to be with me? And there are times where I've had some things that just, pounded me on the head, like, well, nobody wants to be around a person who's critical. Then I realize, boy, I'm going to change on a dime at that point, because...
Before that, you thought you were being helpful. You thought you were diving in and fixing something. And what you got the feedback on when you asked was, dude, you're super critical.
No, I'm enlightened. I've gone from beating myself up or trying to beat up somebody else to get them to do what I want them to do, to realizing that I'm behaving in a way that is going to hurt this relationship, I'm driving that person away, because nobody wants to be around a person who's critical. So it is about me to then realize, how can I be consistently positive? And I discovered that with my son when he was late teenage years, because I was a too tough father. I was critical of him. And he said, no, enough of that. And I realized that if I was just always positive with him, and I didn't try to solve his problems, but I listened to his problems, that we would have a very good father-son relationship, which indeed has happened. It means the world to me.
It's about as good as it gets, I'd say, in that second mountain, to be connected with your son. I think last I checked, I was really thrilled. You kind of moved up and were living near him for the first time in our relationship that I'd known you, and getting to be Grandpa Lloyd a lot. That must be a real That must be a pleasure unlike probably any other.
The best job as a family person is to be a grandparent. You get all those joys and hardly any of the burdens. It is a gift. And particularly, I love young kids because they are full of wonder. They are full of awe, which we've largely lost. But they get up in the morning and everything is exciting. I mean, that's awe, that's wonder, and that's infectious, I find. So I want to be with them because I want to help them, get ice cream or go to practice, soccer practice, in order for them to have the joy, to continue to have the joy in their life, because I'll benefit from that.
Well, Lloyd, it's such a treat to get to spend some time with you. We've got to get another call here so we can catch up on a more personal note. Everybody who's still with us, thank you for your time, and thank you for getting to share in some of the wisdom of just one of the really wonderful minds we have working for us in the background in terms of public mental health. Challenging the mental health system to measure itself, to do better, to be better. Lloyd, you've always emphasized how important it is to listen and prioritize patients, for us not to lose sight that it's about taking care of people. It's about being in service of people and healing them. And that for all of us who've mentored and everyone who reads your work, that comes out so clearly. We did mention a couple books we'll put in the show notes. Lloyd's got a lot of them, the ones that have sticked out. We didn't mention the Ink Stain Life, which is a beautiful biography about some of where Lloyd's kind of business mentality comes from his family business years ago. But the Addiction Solution is really just one of the books I recommend to all of my patients struggling with any types of substance use in their family or with themselves. And then most recently, Caught in the Crosshairs of American Healthcare, I think is very important in terms of the struggles that we're having. And maybe if you in your work to have great mental health and healthcare are having some challenges like that, hearing a little bit of some of the work Lloyd has done and offering some perspective to now is inspiring, and as Lloyd promises, full of some hope. Lloyd, thanks so much for sharing some of your mental fitness tips and to remind us of really what matters. And thanks for all the really kind words you said about me. Those are, I really appreciate those, and those resonate and mean a lot. And I'll take those with me into the weekend. I always like to end with some words of encouragement as we head into the weekend, and whether there is some, I would say, mantras or prompts or ideas or inspiring thoughts that you might have to share with everybody as they seek to improve their mental fitness.
This goes back to why I think the miserable state of affairs in medicine now will change, why I'm hopeful. And hope is what I try to convey to all kinds of people, those who are ill with a mental illness, their families, their employers, their relatives, other relatives, that hold on to hope. Don't give up. Never give up. Because most of our illnesses are persistent, and particularly addiction, which is a chronic relapsing disorder. So you're going to get demoralized. Your patient is going to get demoralized. The family. Those are the key moments to hold on to hope.
Thank you, everyone. Please take those words with you into the next few days. Listen to the very wise Dr. Lloyd Sederer. As always, this time that we spend together is really quite intentional. The hope is that with your focus and dedication to your mental fitness and your mental health, that you will transform and transcend the challenges that you're currently facing, whatever those may be. And most importantly, for you to know that you're not alone in that journey, and that there are a lot of us out here thinking together about how to take care of ourselves, how to take care of each other, how to get through those moments that even great minds with every resource and mental health bit of knowledge you could have, like Dr. Sederer, as he shares, even he ends up in that down, dark place where you have to get up, and provided a lot of thoughts for us and ideas and great feelings about how to do that. Lloyd, such a treat to know you. I feel so blessed to have had you as part of my career so far, and for these next decades to come. Thinking about that second mountain, I look forward to continue leaning on you and seeking your guidance and your mentorship. Thanks so much for coming on to the
The
Mental
feeling is quite mutual. Drew, I feel as heartened by this call as I hope you are as well.
I certainly do, my friend. I'll see. We'll have to have you back on. You have a great, great weekend yourself, and we'll talk more soon. Everybody, have a great one. Thank you. Until the next episode, take care.